team has done an amazing job at organizing a superb schedule, and we're all looking forward to attending all these sessions, जिसमें training village, learning sessions, और live cases, और didactic lectures सारे शामिल हैं. तो a lot of opportunities to learn and hone our skills. और बड़ी global participation, Turkey, China, Malaysia, US, Singapore. तो very few international intervention conferences we see जिसमें इतनी global participation होती है. तो I think kudos to the team जिन्होंने सारा इस तरह setup किया है. तो fellows course का ये है कि स्ट्रक्चरल पहले सेशन इसमें रखा हुआ था, बट बिकॉज हाफ ए डे ही था तो उसको अब कवर करेंगे थ्रू ट्रेनिंग विलेज एंड अदर सेशंस ड्यूरिंग द मीटिंग. तो बाकी जो मेनली कोरनी का सारा इसमें कवर करने का प्लान है. और 10 मिनट की स्ट्रिक्ट टाइम लिमिट होगी फॉर एवरीवन, एंड यह है कि उसके बाद स्क्रीन विल गो ब्लैक. और तो हर एक को एडवाइस यही है कि कोशिश करें मेन सेलियंट पॉइंट्स जो टॉक के हैं विद इन जो है वो 10 मिनट्स कवर करें. और बिकॉज यू वांट टू स्टिक on time and stay on time, and so I think without any further delay I would ask the first moderator, Dr. Rehan Riaz, to come and start the session.
Auzubillahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Thank you very much, Professor Noman sir. I'm Dr. Rehan Riaz. I'm working as Assistant Professor Cardiology at Faisal Institute of Cardiology. And I am honored to being the first moderator in this session. Session is about fundamentals of PCI, and I would like to invite the panelists and chairpersons, Dr. Mujibul Haq, to take his chair, General Azhar Kiani Sahab, General Ashur Khan Sahab, Professor Dr. Hamid Saeed Sahab, Dr. Abdul Salam, Dr. Asad Islam Sahab, Dr. Mohammad Naseeb, Brigadier Imtiaz Ahmed. First talk is on optimal coronary angiography views, and Dr. Khalid Naseeb from NICVD will present a talk. Again, I would request to limit the presentation in 10 minutes. Thank you very much.
Hello, Assalamu alaikum. My name is Dr. Khalid Naseeb. I am Associate Professor in NICVD Karachi. First, I want to discuss the general concept about the angiography view. As a majority of people, we know the caudal views are good for distal LFMS, proximal LAD, and circ. Otherwise, cranial view is good for mid and distal LAD, diagonal and septal and ostial LFMS. In the cases of the overlapping of branches, one principle is always remember, circ move in the same direction as a IE. In the where the LAD move in the opposite direction. For example, in LA view, circ move in the left side and LAD in the right side. In caudal view, circ pull down. What is the foreshortening? The best view for lesions is the orthogonal view. In orthogonal view, we see the lesion from the top of the lesion. In foreshortening, we see the lesion in the same line. So segment in the collapse and the foreshortening segment characterized by very dense. Now, how to differentiate cranial versus caudal? In cranial, you see the diaphragm over the cardiac cell hood, just like here. You see the cardiac cell hood covered by the diaphragm. In caudal view, the cardiac cell hood not covered by the diaphragm. How to differentiate LO versus RO? In LO, open the arm spread, one arm in the spine and other arm in the tip of the catheter. Suppose the one arm in the spine and the left hand on the tip of the catheter left side is the LA view. In RA view, the one arm in the spine and other arm the tip of the catheter right side. Also, direction of the ribs tell us the RO or LO. Totally 6 standard view: LO cranial, RO cranial, AP cranial, and LO caudal, RO caudal, and AP caudal. How's the heart look in the RO versus LO? In RO view, heart look straight in the AV groove, and LO heart look the straight in the septum. It means RO in RA view heart is split into atria and ventricle, and LA view heart is split in the right and left. In the case of the coronary artery fistula, RA view tells us where the coronary fistula drain in atria or ventricle. In the staining, the LA view tells us where the staining right side of the heart or the left side of the heart. Generally, first view we take the RO caudal 2020 is the excellent view for the distal LFMS, proximal LAD, and entire circ including OM. But limitation of this view is the foreshortening of the mid and distal LAD. The second very important view, caudal view, the allocaudal, also note the spider view, is the excellent view, the distal left main, proximal eddy, proximal sulcus, high OM, high diagonal, and also well recognized the ramus branch in this view. But limitation of this view is the abuse patient and vertical heart. I already told about the cranial views. In cranial views, the best view for the mid and distal LAD and septal and diagonal. In allocranial is the excellent view for recognize the left dominant system and mid distal LAD. In the case of obstruction of the LAD and large diagonal, so how this view extend for differentiate the LAD from the diagonal. Diagonal also carry the branches, but diagonal branches not torque and shorten. Diagonal branches torque and shorten, in septal never torque and shorten. This is also important give the quadrilaterals of the right side of the artery. But this view is not friendly for the operator. The maximum radiation the operator receives in this view. Now about the views of the left main. First we want to talk about the ostial left. The best view for see the ostial left in the allocranial and apiate cranial, not a arrocranial. In arrocranial, ostial left is slightly foreshortened, and distal left main seen with the all the caudal views, mainly allocaudal, arrocaudal, and apicaudal. Now I want to talk the views of the right side of the coronary artery. In right coronary artery, usually we take the first view of the LA views, the AV group view. We can see the entire RCA, but foreshortening of the distal segment and overlapping of the PDO and PLV. But we do the cranial view in allocranial, the distal RC is well defined and PDA, PLV well separated, and we can see the easily distal branches of the RCA. But the secondary segment of the RCA foreshortened in this view. Now, RO straight view is the excellent view to the second pound of the RCA, that is straightened, but foreshortening of the proximal and distal segment of the RCA. This view excellent for the see the collaterals of the left system and also coaxial engagement of the catheter or guider. In the case of the ostial RCA lesion, the best view is the allocaudal and the steeper LAD. Now I move the venous graph. This very important slide need to keep memorized. From bottom to top, the first right side lower border of the aorta, the right side venous graph. Above is the interior border of the aorta arise from the diagonal or eddy graph and the top of the OM graph. The downward takeoff of the RCA graph and upward takeoff of the left sided graph. The right sided graph the best engaged in the LO view and left sided branch best engaged in the RO view. First view for the engage the graph and second view according to the insertion of the graph. In RCA we all know the RCA graph insert in the distal portion of the RCA, and already I have told about the distal RCA is well defined in the cranial view. So best views the epicranial and arrocranial after engagement the RCA graft. In opposite in the caudal OM graft, the first engage the venous graft of AMM in RO view and then see the any caudal view, epicaudal and arrocaudal. And if the graph of the LAD or diagonal also engage the RO view and then take the epicranial or your LAD cranial, allocranial. Can you see? Now, I'm talking about the lemma. The lemma is the usually engaged in the AP view. After the engagement, we see the second view, the left lateral view. Left lateral view for the best view, see that in a spongy site of the lemma to LAD. In graph views, the three things very important. First, body of the graph, yausture of graph. Second, cytoestomosis, and third, distal native coronary flow of the vessel. In the case of this work, I'm taking the after a lemma engagement, take the left lateral view for engagement for the atmospheric size of the lemur to LAD. In the case of the old age or patient with the stroke can't move the arm above the head, we alternatively with the RO straight view or allocorder. RO is depend of the insertion point of the graft. If the graft insert in the distal part, the RO straight view. If the graft insert in the proximal part, the allocorder view. Thank you.